Hi and welcome to Policy Unpacked, a podcast by Global Policy Network. In this series, we dive into policy shaping our world, from healthcare to sustainability to education, and explore how these critical areas intersect to drive meaningful change. Whether you're a policymaker, practitioner, or just policy curious, we're glad you're here. Let's unpack policy together. I'm Maya Asher-Jones, Communication Lead at Global Policy Network and producer of this podcast, and I'm excited to host this week's episode. Today, I'm excited to be joined by two contributors to our latest policy report, Dr. Jihad Malasi and Yijun Yoon, as we discuss our latest policy report, Shaping the Future of Primary Care, Priorities and Challenges over the Next Decade, which is based on the findings of our roundtable of the same name, which was held late last year. Dr. Jihad Malasi is a GP, a member of the NICE MedTech Committee, and an ICS mental health clinical lead in East Kent, bringing both a frontline and system-wide perspective on primary care and mental health integration. Jihad was also a speaker at our inaugural primary care roundtable at the HETT London conference last October, which serves as the basis for this report. Yijun is a Global Policy Network Fellow and university student studying economics and sustainable development who supported the research and drafting of this report. It's great to have you both with us today.
Thank you for having us.
Okay, so we're going to delve into the background a little bit. Jihad, as we've mentioned, you're a speaker at our in-person roundtable at HETT, and we were so grateful for your support. How was that experience for you?
It was great to be among colleagues, with an incredible depth of experience and to share our thoughts and concerns and, hopes for the future of the NHS. And I think it was great to have representation from charity sectors, innovation, and people with specific issues, with subject matter expertise that really gave us a different perspective. So I think that was really valuable for all of us to hear. And although time was limited, we were able to discuss, a really wide range of issues in some depth and some issues in some detail. So I felt it was very thoughtful and a rare opportunity for us to, genuinely bring a constructive and interdisciplinary discussion with one another and so on. We often work in silos and in individual organizations. So, it was a chance to offer reflections from different aspects of the healthcare system and, in a way, how we see the NHS moving forward together. So I think we touched on primary care, which is, a really multifaceted, it has a multifaceted nature with pharmacy, optometry, and other, really important elements. The interface issues, the role of the voluntary and community and faith sectors. So I think it was a really valuable discussion.
That's great. And Yijun, you've been a fellow for a few months now. How's the fellowship been for you and what experience have you gained?
Well, I'd say that the fellowship has definitely been a transformative experience for me. And I have to say, coming into healthcare as someone new to this sector, I think that's all contributed to making it an even more enriching and eye-opening experience. And I remember when I first joined the Global Policy Network as a fellow, healthcare wasn't really an area that I had really deeply immersed myself in professionally. My background lay elsewhere, so stepping into the world of primary care and NHS transformation was initially quite daunting. But that's why I think this fellowship is so valuable. And I was able to approach these issues with fresh eyes. So yeah, it's just been an incredible journey, and I'm grateful for every conversation that I had with my fellow teammates and experts like Dr. Jihad.
That's great. I can definitely relate to that experience. Jihad, Yijun, you're not only GPN fellow and GPN advisor, but also uncle and nephew, and you've worked together on a policy report. How did that personal connection shape the way you've collaborated, and what did you learn from each other while translating lived experience and professional experience into policy?
Oh, shall I go first?
Yep, sure.
Yeah, it was fantastic to work with Yijun, really. I mean, he's got this deadly combination of being affable, hardworking, and clever, which is, incredible to have on your side, and probably annoying in equal measure, you know. But he probably didn't want me to say this, but he's worked incredibly hard to get into Columbia University, and something that he's passionate about, and I've known for a long time. He's been into sustainable development and economics. So I am, I'm very proud of him. Of course, I'm proud of you, really. And I think it's also something that Malaysia needs. So I hope you take the learning back to Malaysia and do something useful with it, because people need that.
Oh, wow. Thank you.
Oh.
Thank you so much. I appreciate that so much. But on my end, I think like working with Uncle Dr. Jihad on this report definitely was a really unique experience, because I think we both brought really different things to the table, and our personal relationship made that much easier to navigate. And for me, coming into healthcare as a newcomer, I think having Uncle Jihad as both an advisor and family member was a blessing, because then I have someone I could ask the basic questions to without feeling embarrassed. When I didn't understand why GP partnerships work the way they do, or what certain acronyms stood for, I could just ask. And above all, it's just incredible to have such a close relationship with Uncle Jihad here, who's a leading expert in primary care and healthcare in the UK.
Well, very, very kind words. I mean, I wouldn't consider myself those things, but I've been in the system for a long time, so I could answer some of his questions. But as for the report itself, obviously a lot of hard work has gone into it, and I think it's important to acknowledge the work of Alicia and Rita and the other GPN contributors who have put in a lot of hard work to make the report robust and be useful to people, practically useful to people. And that's my hope for it, really. I hope it'll be well received and be a useful contribution to our policy discussions.
Yes, indeed. We have a great policy team here at GPN, so big thank you to all of them for working so hard on this report. And it's finally paying off, so congratulations. Let's get into the content of the report a little bit. So, Yijun, one of the report's key insights was that the NHS is structurally unified but operationally fragmented. Based on the roundtable and the brief, what have you found about fragmentation and what it actually looks like in everyday primary care?
Well, I'd say that the fragmentation isn't chaos. It's something more subtle, more of problems to do with structure. So what became clear in the roundtable is that we have four main contractor groups: general practice, community pharmacy, optometry, and dentistry. And I think Dr. Jihad mentioned that just now. And they all operate under completely different contractual funding and commissioning models. So GPs work on capitation and quality payments, pharmacies on a nationally agreed framework, and dentists on activity-based UDA contracts. And so you see these differences create fundamentally misaligned incentives in the system. And what struck me was hearing that this coordination isn't really built into the system, and it has to be actively commissioned. So you have all these contractor groups, GPs, pharmacists, optometrists, all serving the same patients, but there's no automatic mechanism for them to share planning or connect digitally. And it all depends on local relationships and whether someone has put in an effort to create referral pathways or shared protocols. So I think essentially this is what fragmentation might look like day to day. It's maybe you can see this in a patient moving between services and then encountering repetition and delays. So you have all these different parts of the system that are working hard and brilliantly, but they're not working together in the best way possible because the structure doesn't enable it.
That's amazing. Thank you. So, Jihad, from your experience as a GP and mental health system leader, how do these misalignments show up for patients, particularly those with complex or overlapping needs?
Yeah, I think Yijun has described the situation well. In my experience, we try to, as much as we try and co-design services with patients, particularly those with lived experience, or what we call PPIE, patient and public involvement, we often default under pressure to design services that fit us as commissioners. So we might have a strict financial envelope, we might have inclusion and exclusion criteria, and that the new service should fit within a suite of other pre-existing services. So it's sort of layer upon layer of services. And inevitably it meets if you're thinking about the bell curve of the population, that the services we design probably at best meet the needs of those right in the middle, but not those that fall on the periphery or the edges. So if you have a co-occurring condition, or you have a severe mental illness and a long-term physical health condition, you fall between the stools. Or for example, in mental health, you might have a psychological condition, but what you need is long-term psychological support, but you can only access primary care support because access into secondary care has a high bar. So there are, distinct gaps between those systems that we design. So that's in a sense why gaps are created, and we don't fit services that populations often need from us, and that's something we need to learn and improve on.
Brilliant. So, to both of you, the report talks about the idea of a primary care family. What would meaningful integration look like in practice without dismantling existing contractor models?
Yeah. So I think definitely working with my team on this, it's we realized that one of the risks in this space especially is assuming that integration only happens if you redesign contracts or centralize everything. And the roundtable was very clear that this isn't the realistic route or even desirable in the short term. And when we talk about a primary care family, we're not talking about dissolving the independent contractor model. So meaningful integration should be much more practical than that. I think it's how services behave together, not who formally owns the contract. So maybe in practice, it could look like a few things that we highlighted in the report. So maybe first we could look at shared pathways that are agreed locally. So GPs, pharmacists, dentists, optometrists, and community teams know who does what, when, and why. And we find that might be effective in reducing duplication and stops patients being bounced around in a way. And also, secondly, very importantly, in this day and age, shared data and interoperability. So if different parts of primary care can see the same relevant information all at the same time and update it in real time, then care can feel joined up even if contracts remain separate.
Yeah, no, they're great points. I think the government is obviously trying very hard, I think, through its 10-year plan and what they're calling left shift, which is trying to move services from secondary care and what I call the things that go beep, into primary and community sectors. Because you think that if you look at the pyramid of population need, for example, you have a much bigger population with lower intensity needs at primary and community level, and that's where you can make significant savings. The other element of that is trying to stratify patients into high risk groups. And in our area, we're using the Johns Hopkins stratification tool, and that divides patients into what's known as PGNs, or their specific groups from 1 to 11. And the groups 9 to 11 or 10 to 11, cost the system, if we're talking about nuts and bolts, cost the system, it's 50% of the cost, or even 60% of the cost if you just include 8 and 9 along with that. So it's about designing services that meet those needs in a proactive and sensible way, and also enhancing what primary care can do. And at this point, it's also important to talk about the new potential neighborhood care that we're talking about now. That at the moment is still undefined. It's not clear to players in the system exactly how that's going to work. But I believe the intention is to bring together, primary, community, voluntary, faith, all of these different organizations, including, for example, the police, or maybe ambulance services, or some specific services that, if you think about criminal justice and discharging people from prison, for example, what do we do with those populations, or the homeless? So I think neighborhoods represent a really useful way of framing that discussion. And I hope that there will be financial mechanisms that move a certain amount of funding, not much, but I think a sufficient amount of funding so that we can enable those things to happen. Yijun obviously touched on digital, and that's, I think, a very important aspect as well. I'm sure we'll come into that. That will come later.
Yeah, brilliant. Okay. So the report argues that primary care needs to be reframed around prevention rather than crisis response. Yijun, from your research, do you think prevention could be hard to embed in policy and delivery?
Yes, I think it will be hard, but maybe not for the reasons that people might think. So I think the challenge isn't really that people don't believe in prevention. I mean, everyone, from the policymakers to clinicians, they all agree that it makes sense. The problem is that prevention requires huge upfront investment with returns that can only materialize like years down the line. So that means like we often have to wait beyond budget periods or electoral cycles, and I think that's a tough sell when hospitals are full even today, when waiting lists are long today, to think about the longer horizon. So what our research showed is that the barriers to prevention are more structural and not conceptual at all. So right now the system is set up to reward activity. So how many patients you see, how many procedures you perform, and prevention doesn't really fit neatly into that model, you could say. So how do you measure the heart attack that didn't happen, right? And how do you pay someone for stopping a person from developing diabetes in the first place? So that's also, yeah, and there's also the funding reality. I think we heard repeatedly in our roundtable that there's no new money coming into primary care. So embedding prevention means making really difficult choices now about what the system stops doing to free up resources for earlier intervention. And politically, that could be really challenging. And that said, I don't think it's impossible. We are not like recommending a whole complete system overhaul in one night. It's about creating the conditions that make prevention, viable. And we've seen pockets of success, like community paramedicine in Canada, or like Dr. Jihad said, integrated neighborhood models, like in Bromley by Bao. And it shows that it can work when there's local leadership and stable funding. But scaling that nationally would require political will and willingness to make these hard trade-offs. So yes, I think embedding prevention will be hard, but the alternative, which is to continue to fund crisis response while all of prevention continues to fall through the cracks, I think it's ultimately more expensive. So it's up to whether the NHS or the UK healthcare system is prepared to do the difficult work.
Mm-hmm.
Yeah, in many respects, I think it's partly to do with political will. I mean, Yijun talked about election cycles and how health and social care, for example, are beholden to slightly different masters. So when you look at social care, they respond directly to elected officials, whereas the NHS is slightly separate from that, although I think there is more central government control with the latest transformation that's happening within the NHS. But nonetheless, we respond health and social care as two sides of the same coin, respond differently to public pressure and scrutiny, I think. At the same time, I don't, if you take the analogy of a house, what's the point in replacing the carpet while there's a hole in the roof? So I think it's right that we look after prevention and that we really respond to that and think more long term and try and separate ourselves from these political headwinds and so on, and try and do something for the long term. There are practical ways of doing that. So you could set up a contract for 5 years or 5 years plus 2, so a total of 7 years, for example, which will take you through 2 parliaments, depending on the cycle. You could have even longer contracting, for example, and I think there are good examples of that. The other big question is about what is prevention? You know, what truly is prevention? Where do you draw the line? Because you might say to a GP that actually you do perform primary prevention. You offer people antihypertensive drugs to prevent their blood pressure going up in the long run and preventing stroke and heart attack. And at the same time, you give people statins. So you obviously optimize their cardiovascular morbidity and all of that. So that is prevention. But is a GP's role to put disease to one side and focus more on the truly preventative things? Is that the role of primary care? Is that the role of pre-primary care? You know, the voluntary sector, for example, going on community runs, or social groups, improving your your social network, for example. That's shown to prolong life. So there are big questions for us about how prevention actually works and how it's defined. But in terms of mechanisms, of course, I talked about stratification. There's also population health approaches. So I think there's a lot we can do in this space. There's also a lot of reports. There are a lot of reports that quote return on investment, particularly when you look after children, for example, and many others too. There are many ways, to move forward. But I do think that there's some political will and some thought given to how where prevention lies and whose responsibility it is. We need to think about that more closely.
Definitely, definitely. So to both of you, if prevention became the organizing principle of primary care, we've touched on this a little bit, but what would you need to change first? Funding, workforce models, or digital infrastructure?
Go on, Yijun. What are your thoughts?
Okay. Yeah. I think if you're forced to, I mean, obviously the honest answer from the roundtable is that you can't just pick one, but if you're forced to choose a starting point, I think funding has to move first, because at the end of the day, funding sets the behavior for the system. So as long as primary care is largely rewarded for activity and short-term demand management, I think prevention will always sit at the margins. And then, so, when you shift funding toward longer commissioning horizons and perhaps outcome-focused incentives that could create the permission structure that would allow prevention to happen. And then after funding, I mean, once funding begins to align, then you can look at workforce models, which can evolve then more realistically. Then finally, I'd say digital infrastructure comes next as an enabler rather than a driver. And the roundtable is very clear that technology only supports prevention when it's designed around real patients and clinicians. So, but even without aligned funding and workforce capacity, digital tools don't mean anything, and instead they risk widening inequalities. So the sequence matters a lot. Funding enables the prevention, and then the workforce delivers it, and the digital infrastructure can enable and amplify that entire process.
Yeah, I agree with most of that, really. It's for me, I think the political will comes before the funding, probably, purely because this country has rich areas, poor areas, coastal, rural communities, vested interests. A London-centric country versus areas of the northeast that don't see a great deal of funding relative to the south. So I think there's some discussion that needs to be had and some political will that needs to be, genuinely, engaging with the population so that funding can shift. So for me, that's very important. I used to be the clinical chair of a clinical commissioning group, and we were small. We looked after 148,000 people, and our budget was around 230 million pounds, thereabouts. But over the years that we worked together in that group, we didn't, we did a lot of good work, but we were not able to shift the dial significantly, and that's because I think that there was not enough political will to try and move money and services into poorer areas. and so we have a battle over there. I think we have a real hearts and minds discussion to win there. I think we have a Labour government. I don't know if they're doing very well at the moment, but we can live in hope. So the second part of that is probably rebalancing health and social care with the funding. I think that's important too. And again, that's not an easy ask because hospitals, as Yijun said, are struggling. And I have full sympathy with them with corridors full. Workforce modeling and digital infrastructure run alongside that, as we like to call them enablers, but they have to run alongside that. But yeah, a big task.
Definitely. So, Jihad, the report is very clear that voluntary and community sector organizations are essential, yet financially fragile. From your experience, what risks does that instability create for patients and services?
Yeah, I think the voluntary and faith sectors have the potential to be a game changer. They have a real chance to change the way that we deliver care, particularly at grassroots level. And people used to look at the voluntary sector, and that voluntary connotation, almost makes them sound like a charity, and that they're not really part of healthcare. But more and more, there's an acceptance that we commission them on an equal footing with NHS services. And for my sins, I'm a non-executive director of Social Enterprise Kent. I don't mind plugging them. I think they're amazing. And they do a huge amount of work looking after patients with cancer, training people up to do, all sorts of things within the healthcare space. So I think it's very important that we support them. Unfortunately, relating to your question, they receive much of their funding from charitable sources, from the big lottery funding, from lots of funding from councils, which are social care. So that's not stable, I agree. I think we need to be a bit more deliberate and a bit more thoughtful about how we fund them in the long run. For example, in mental health, we have something called the Mental Health Investment Standard, which is ring-fenced. And I think there could be an argument made that they provide such good value that we should offer a circumscribed pot of money that sits between health and social care to support these organizations.
So, to both of you now, what role should the integrated care boards play in creating stable, equal partnerships with community and voluntary organizations?
Yeah, I mean, we can take it from here. So we think that ICBs need to move from transactional commissioning to more genuine partnership, and that has to start with funding stability. So right now, voluntary and community organizations, they are all delivering essential prevention work, mental health crisis support, and also community outreach that the NHS can't replicate. But they're doing it on short, precarious contracts. Sometimes you're looking at timeframes of just 6 months or a year. And you can't build sustainable care pathways when organizations don't know if they'll even exist in a year. And I'd like to bring up something Dr. Jihad mentioned as well previously. We are recommending something like a ring fence community integration fund, similar to the mental health investment standard that's protected mental health spending for over a decade. It's a multi-year. When we look at this, multi-year predictable funding would allow these voluntary organizations to plan their workforce and actually function as stable partners rather than just gap fillers. But it's not only about the money. I think ICBs need to trust these organizations to hold real responsibility and deliver substantial contracts. And many of these voluntary organizations have been serving their communities for decades, and they have these deep relationships and cultural knowledge. And so these expertise should be recognized and valued. Ultimately, these ICBs should see voluntary organizations as core infrastructure for prevention. And once that mindset shifts, then the funding models and governance relationships, I think, could follow and will follow naturally?
Yeah, at the moment, the NHS is, I agree with those points. I do. At the moment, the NHS is reconfiguring itself, and ICBs are merging to save costs, and they're losing 50% of their workforce. So I think it's important to acknowledge that at the moment. That's the current reality that many people are living through, including myself. And so I think they're going to be moving into more strategic commissioning, which means that they will be smaller and devolve more of that kind of authority to commission, I think, to larger organizations like trusts. Not larger, but large organizations like trusts. So that commissioning function may move down to trust level, to large hospital trusts, multi-hospital trusts. So I don't know what that means in terms of actual commissioning, because that's not clarified in my mind yet. But I think the principles are the same. Things like an equivalent to the mental health investment standard, that could be very interesting. Multi-year contracting with them would be very interesting too, because I think they have a good return on investment. And we have good examples of it too. So we have experience of working with them. The examples of that are in my space, in mental health, crisis houses and safe havens, for example. We have a good collaboration with them, and the contracts that we ask them to deliver on have the same metrics and KPIs and safeguarding and governance as you would see in a standard NHS contract. In fact, you probably see them comply with it better than some NHS organizations, because they're new to the game and they want to prove their worth. So it's really interesting to see them work in that space. So yeah, agree with the points that have been made, but I think we need to see what's happening with ICBs. Yeah.
Definitely. Okay, let's move on to digital transformations. Yijun, digital transformations are often presented as solutions, yet this report warns that it can widen inequalities. What stood out the most for you from these discussions?
Yeah, perhaps what stood out most was probably this gap between the promise of digital tools and the reality, how unevenly they're actually working. So there was this moment that we love to quote, in the roundtable when someone described an older woman with a leg ulcer, and it worsened because she couldn't travel for assessment and she wasn't able to upload a photograph of her wound. The technology existed here, right? But it just wasn't accessible to her. So, what should have been what should have been early preventable care dragged on and became a crisis admission. So I think maybe that story really epitomized the problem. Digital transformation only works if it reaches the people who need it most. And if you look at the data, it backs it up. We found that 33% of hospital trusts still can't access external patient data electronically. And these systems, they work brilliantly in London or Greater Manchester. Again, we're talking about the urban-rural divide. But they simply don't exist in rural or coastal areas. And when the technology is available, there are still huge variations in digital literacy between among patients and staff. And what the roundtable, made clear is that perhaps digital equity isn't about giving everyone the same technology. It's about ensuring the technology serves everyone's needs. And that could mean different solutions for different settings. Community pharmacists might need different digital tools designed around safe dispensing workflows. And rural practices, on the other hand, may need infrastructure that actually works with their connectivity, not systems, designed for London or Greater Manchester. And the recommendation we landed on is that any digital strategy has to be explicitly equity focused from the start. And that means protected time and training for staff to actually learn these systems. We don't want to have it just having them dumped into practice. So overall, I think digital transformation has enormous potential, We saw that with tools like AppTrace using machine learning to detect long-term conditions earlier, or integrated care records improving coordination. I mean, when they work properly, right? So the lesson is clear. Technology only transforms care when it's implemented thoughtfully and equitably. Otherwise, it runs the risk of deepening the divides that already exist.
Yeah, so I think there are many ways to cut this question, particularly on digital transformation. There's, elements of patient safety, and I think, within our sector, particularly the healthcare sector, we move rather slowly compared to other sectors, and that's really to do with concerns over patient harms, because if you use the large language models, for example, they have the potential to reach millions of people. So those harms could be amplified across a large population. In particular, I can give you the example of the Federated Data Platform and a project called Foresight, which was published in the Lancet Digital. And there's been a challenge raised by the Information Commissioner's Office, the BMA, and the Royal College of General Practitioners Committee, the one that focused on technology. And they've looked specifically at this, and they're asking questions as to whether the right permissions were sought, and all sorts of questions around governance. So I think this is a kind of a microcosm of what we'll be facing in the future. So there are those kind of elements. There's also routes to market for technologies and how they can actually embed and translate into clinical care. Part of that question, I think, is to do with having the right technologies for unmet need, as opposed to technology companies developing what they like, and also distinguishing what is wellness, which is not necessarily evidence-based, and healthcare, which is evidence-based and requires regulation. So that's a very specific area, I think, that that we're seeing unfold in the market. And digital transformation isn't just about technology, it's about people. So it's about culture, how you bring people along with you to buy into what it is you're doing. So that I think that it has, obviously, as Yijun said, the potential to be an incredible game changer. And in many ways, I think it will move beyond us very, very quickly. But at the same time, we need to place safeguards and, use ethical frameworks to make sure that it's good for patients.
That was brilliant. Thank you so much. That's all we have time for today. Thank you, Jihad and Yijun, for such a thoughtful and grounded discussion. This report makes clear that the future of primary care doesn't hinge on creating entirely new structures, but on better aligning the ones we already have around prevention, integration, and people. Do you have anything to add, either of you?
Yeah, go. Please, if you have the chance, please go ahead and read our report. Hopefully, you'll gain something from it. And we, from the team, we thoroughly enjoyed working on it, especially collaborating with experts like Dr. Jihad. So yeah, do give it a shot and let us know what you think.
Yeah, and it's been a pleasure working with all the fellows at GPN, like Alicia and Yijun, and a pleasure to work with the team in the background, Maya, yourself, and others. So I'm very grateful for the opportunity. So thank you so much.
Thank you again, and thank you to the team again. So this coming year, the Primary Care series will continue with more roundtables, reports, and podcasts from our audience. Meanwhile, listeners can download the full policy brief from the Global Policy Network website. Make sure to give Global Policy Network a follow on all social media and watch out for a new episode every week. Goodbye.